Good afternoon. I'm Dr. Ashish Singh from Department of Hepatology, Christian Medical College, Belgaum. And today I'm here to discuss the role of plasma exchange to treat idiosyncratic drug-induced liver injury. Drug-induced liver injury is a term used to describe unexpected harm that drug can cause to the liver that can range from asymptomatic elevation of enzymes to liver failure. Idiosyncratic liver injury is a common cause of acute liver failure as described in US ALF group and amounts for around 5 to 13% of all ALF cases. Similarly, data from the Indian DILI network has shown that around 14% of all causes of ALF are due to drug. The study from the Asia Pacific Association for Liver Failure constitute that drug amounts around 11% of all acute hit to the patient of underlying chronic liver disease. This is a study done by the US DILI network published in 2015, in which they have recruited 899 patients, and the most common cause of drug-induced liver injury was antimicrobial, of which amoxiclav was the major cause. That was followed by herbal and dietary supplement that amount around 17%. The data from the Indian DILI network that have analyzed 1,288 patients, the most common agent for DILI was anti-tubercular drug, that followed by complementary and alternative medication, followed by anti-epileptic drugs. To diagnose the DILI, as we know, it is a diagnosis of exclusion. So there should be a meticulous history that shows the temporal profile of the patient, his drug intake, followed by the calculation of R ratio, that is a ratio of upper limit of AST with alkaline phosphatase, and it shows the pattern of liver injury, whether it is hepatocellular, mixed, or cholestatic. Followed with, we have to rule out the other etiologies such as cause of acute viral illness, rule out ethanol intake, rule out other metabolic causes such as Wilson disease. The patient should not have any hypotension or any biliary obstruction. We also need to rule out underlying autoimmune disease. So the treatment options are limited, with the major aim of the treatment is to stop the underlying drug and to avoid re-exposure of the similar drug. The US ALF group had analyzed 122 patients with DILI, and they mentioned that transplant-free survival is around 27%. The study from Lee et al. Has used N-acetylcysteine, and that has shown to improve the transplant-free survival from 27 to 58%. Similarly, in a study done by published in Hepatology in 2014, in which out of 131 patients they have analyzed, that some received steroid, and of received steroid, there was 69% survival, and who did not, there was 66% survival. So there was no documented benefit role of steroid. So in a nutshell, the early referral for transplant to the patient with acute liver failure is the treatment of choice. So there is a lacuna in the other alternative treatment management apart from transplant. So one of the therapy is plasma exchange. So plasma exchange basically means plasma pheresis, that is removal of the plasma, and to replace that removed volume by fluid, there of which the fresh frozen plasma is the preferred fluid. There are 3 types of plasma exchange, and in the West, the study from the Larson et al. Used the high volume plasma exchange, in which they exchange the 4 times the volume of plasma. There are the 2 types: the standard volume, that is done in ILBS from Delhi, in which they exchange the 1.5 to 2 times of the plasma volume. In our center, CMC Vellore, we use low volume, that we replace around 0.5x, the half the volume of the plasma that to be exchanged per session. Our experience is plasma exchange for different liver syndrome. The major is acute liver failure, that amounts of 47%, followed by acute and chronic liver failure, of which the 2 major group are alcoholic hepatitis and drug-induced liver injury, followed by some 18 patient in intrahepatic cholestasis and some patient with sinusoidal obstruction and primary non-function of graft. Etiology-wise, the most common etiology we have worked on was ethanol, followed by rat killer ingestion. It is similar to the paracetamol poisoning in the West. In the West, we see retol ingestion of. So we have done 65 patient of rat killer poisoning with plasma exchange, followed by 44 of idiosyncratic drug injury. So now I'm to take you through some cases for which we have done the plasma exchange. So this male, 22-year-old male with no significant ethanol consumer had pain, abdomen, nausea, vomiting, was seen locally and was prescribed antiemetic and pantoprazole. However, his symptom doesn't improve. He took herbal medication that was combination of 7 medication on 15th of January and took another dose on 16th. On 18th, his family member noticed that he was disoriented time person and was having excessive sleep cycle. So he was brought on in CMC casualty on 19th. During initial assessment, he was stuporous, there was icterus, hemodynamically he was stable, respiratory, cardiovascular, as well as abdominal examination was unremarkable. His GCS was 10/15. He was in grade 3 encephalopathy. Pupils were bilateral equal and reactive, and plantar were bilateral flexor. In casualty, his baseline total bilirubin was 17.9, SGOT of 290, SGPT of 206, and alkaline phosphatase were 200. The other common cause of acute liver failure, such as acute viral panel, were negative. He was negative also for Epstein-Barr virus as well as CMV. His autoimmune liver profile was negative. R factor was calculated, that was 3, that correspond to mixed pattern of drug-induced liver injury. His INR was 3.78. Ultrasonography did not reveal any biliary obstruction or any underlying liver disease. Subsequent liver biopsy was done that showed mixed portal, periportal, lobar perivalvular inflammation, along with mild mixed micro and macrovascular steatosis, with impression was keeping in with the acute liver injury. So diagnosis was acute liver failure with etiology being herbal drug. He was fulfilling the King's College criteria for urgent liver transplant. He was fulfilling the 3 criteria out of 5 for urgent liver transplant. The plan was discussed with the family. They were not on board for transplant, and the option was plasma exchange was given. So he underwent 2 cycles of plasma exchange, one on 19th, another was 23. As shown in this slide, there was improvement in the total bilirubin level as well as the SGPT level. The INR from baseline 3.78, at the time of discharge it was 1.6. The similar improvement was seen in the MEL parameter from 31 at the time of discharge, it was 22, and in the last follow-up it was 6. His GCS also improved from 10/15 after 2 sessions of plasma exchange to 15/15. So he underwent 2 cycles of plasma exchange, that was low volume, around 1400 ml was plasma was exchanged. He also received IV mannitol for cerebral edema protocol and acetylcysteine, UDCA, as well as zinc phosphate. He was discharged in the stable condition after 19 days of hospital stay without need for liver transplant. This is a case 2, 27-year-old female, known case of seizure order, was on levetiracetam and clobazam since 2016. On 2017, 3rd December, she was introduced to sodium valproate. On 25th October, she had low grade of fever along with malaise and lassitude. On 1st of November, she had ultrasensorium. There was no history of any jaundice, GI, bleed, rashes, or petechiae over the body. She was brought to the casualty. In casualty, she was tuberous with GCS of 11/15 and grade 2 encephalopathy. Rest of the system were normal. In casualty, her total bilirubin was 2.2, SGOT of 5,592, and SGPT of 3,654. Her acute virus panel were negative, and she was negative for autoimmune liver profile. Her R factor was calculated and it was more than 5, corresponding to the hepatocellular pattern of injury. Her INR was 2.42. Her ultrasound do not reveal any biliary obstruction or underlying liver disease. Subsequent liver biopsy shows mixed infiltrate of lymphocyte, histiocytes, and plasma cell. There were many areas of hepatonecrosis seen in the portal periportal region. Along with the parenchyma shows swollen hepatocyte and diffuse mild macrovascular cirrhosis. So diagnosis of acute liver failure with probable culprit being sodium valproate. As transplant was not an option, she underwent 2 sessions of plasma exchange, one on 4th and another on 5th. After 2 sessions, there was improvement in the SGPT, LOS, total bilirubin level. INR improved from 2.42 at the time of discharge to 1.27. Similarly, the MELD parameter from 20 has improved in the last follow-up till 6. Her GCS also completely resolved from 11 to 15 to 15 by 15 after 2 sessions of plasma exchange. So this is a temporal relationship. On 2017, she took valproate. There was DILI episode in 2017 after plasma exchange of symptom, as well as there was improvement in the liver function test as well as INR. This case 3 is in 42-year-old male who is a diagnosed case of chronic liver disease with index was hematemesis and underlying etiology with hepatitis B virus. EVL was done and he was kept on beta blocker and EVL protocol. His lamivudine was changed to tenofovir in 2016. He was well compliant to medicine and was regularly following up. On 2nd of February, he had 1 prodrome of fever with sore throat, was seen by the local practitioner and was given amoxicillin, clavulanic acid, paracetamol and omeprazole. After 15 days, he presented it to casualty with worsening of abdominal distension that was has present only since the last 3 days and has gradually worsened. He also given history of jaundice in the last 10 days. There was no history of any altered sensorium, decreased urination. On examination, there was icterus was present along with free fluid. Other systems were unremarkable. Her baseline bilirubin was 26.25, HGOT of 171. Acute viral screen was negative for A and E. He was already a known case of hepatitis A, hepatitis B virus. His IgM score was negative. His INR was 1.7 and other autoimmune liver profile was negative with background changes of cirrhosis was seen in the ultrasound abdomen. So the diagnosis was acute and chronic liver failure according to the apostle definition with acute culprit with drug and chronic with hepatitis B. He had grade 2 ACLF with R score of 8, MELD of 26. Her RUCAM score was 6. So the underlying culprit drug was stopped. He was started on N-acetylcysteine along with continuation of tenofovir. However, there was no improvement in the R score in the next 48 hours. After discussing with the family, he underwent 3 sessions of plasma exchange along with low dose of steroid. So this is the slide showing that patient underwent 3 sessions of plasma exchange on 18th, 19th, 20th, following which there was the improvement in the bilirubin level as well as the transaminase level. INR also from time of acute hit 1.73 gradually improved to 1.40 and the VWF, that is a predictor of mortality as well as severity in the ACLF group, along with ferritin, that is a marker of reticular inflammation. So both VW and ferritin from the baseline gradually improved till the last follow-up. His MELD also from 26 has improved to 16th. So now this slide shows our experience in treating idiosyncratic DILI patient with the help of plasma exchange. So till now there are 44 patients, of which 25 was acute liver failure, 19 of ACLF. Male is 25, followed by female as 19 patient of female. The RUCAM score was 38 and of probable and possible in 6 patients. With the most common agent in our group was complementary and alternative medication around 22 patients, followed by 11 patient has antimicrobial as culprit, with amoxicillin is the major in that group. Most of our patients had jaundice, 100% had jaundice, 68% has ascites, and around 27% have encephalopathy. The median MED was 13.25 and SOFA score of 8.4. In the cohort of ACLF patient, the mean CTB score was 11.6 and R score was 9.6. According to the partial ACLF grade, 11 patient was in grade 2 ACLF and 5 were in grade 3 ACLF. In the ALF group, out of 25, the 20 patients were fulfilling the King's College criteria for urgent liver transplant. This is the outcome of the patient for Plex done for IDILI. So out of 44 patients, there was 68.18% survival noted. In the ALF group, the survival was 56%, and the ACLF group, the 30-day survival was 84.21%. In acute liver failure group, out of 25, the 20 were meeting the King's College criteria for liver transplant, out of which 12 patients, that is around 60% of patients who met KCC criteria, improved with plasma exchange without need of liver transplant. Similarly, in ACLF group, the 30-day survival was 84% and 90-day was 64%. The study done by a partial group in patient with DILI, the 90 days survival in that group of cohort was 47% with the standard medical treatment. So to summarize, drug-induced liver injury is an important cause of liver failure syndrome. The main aim is the prompt identification and stoppage of harmful drug. Liver transplant is the only available treatment in case of DILI that present with acute liver failure. So we propose that plasma exchange should be considered as an effective and safe liver supportive therapy in patients with drug-induced liver failure. Thank you.